Okay. I think I can't wear my glasses because I've got these other things on. Good morning, and let me begin by thanking the Foundation for inviting me to this wonderful conference. I really feel very honored to be here among all of you, and just to learn so much about the work that you're all doing as well. So this morning what I want to do is to talk about the research that I've been doing for the last many years, too many years, focusing on language in autism. Okay, so the outline, I'm going to start off by speaking about what the place of language is in the disorder of autism. We'll talk about what kinds of language impairments we see in children with autism and also in family members, and then move into the work that we've been doing on trying to understand the brain bases of these differences in language. I'll then move into talking about very early development to focus on how early do we see these atypical patterns, when do they emerge in development, and then finally I will end by talking about the most recent work we've been doing, which is focusing on those children who don't acquire spoken language to any great degree, even after they've received a lot of intervention. So these are the children we refer to as the minimally verbal, and then come to some conclusions. Okay, so what is language? Well, language is a very complex and multifaceted construct. We can think of it primarily as a code that we use for transmitting information. This is what we call the linguistic code. It's made up of the sounds and the grammar and the vocabulary of language. But all of that, the structure or the linguistic code, serves communicative needs. That's why we acquire language, is to be able to communicate with one another. And that's what I call the social code, how we use both the linguistic and then non-linguistic cues, our gesture, our intonation, facial expressions, and how we modulate the way we speak depending on different social contexts. Now, when we think about autism, you don't have to be able to read all of this. What we see here are the core symptoms that define autism, and those fall into two domains: social communication impairments and the presence of repetitive behaviors or restricted interests and sensory symptoms. That's what we see in green in the middle. That's how we define autism. But I hardly can think of a single autistic child that I've ever met, and I have met many, who only have the core symptoms. In fact, in every individual, more or less, you see these co-occurring conditions, and they fall into different categories. Do they have a co-occurring genetic syndrome like Fragile X syndrome? Or do they have other kind of biological problems? Do they have medical comorbidities like sleep disorders? Do they have behavioral comorbidities, anxiety, depression, and so forth? And then the cognitive comorbidities here, which include intellectual disability and then language. So at this point, language, which used to be considered a core symptom, isn't really a core symptom anymore directly. But as I'll go on to say, the way we think about language and communication more broadly in autism today is that there are core universal problems in language use in the social code. And we see this across the spectrum: inability to communicate effectively, and that can be, of course, at mild or at more severe levels. So we do see universal impairments in the social code, but the linguistic code is really where we think about language as a co-occurring condition, because we see huge heterogeneity, more so than in any other disorder that we could think about. We're going from people who are completely nonverbal, to having superior linguistic skill. And I was telling one of you yesterday about this young man who I knew who kept on learning new languages. He just loved the linguistic code and wanted to master the linguistic code of many, many different languages. And so he clearly had superior skills in that area. Someone who basically speaks only one language, I really appreciate and admire his skills. And there's, of course, everything in between. Even though it's not a core symptom, this is the single best predictor of long-term outcomes. Independence, it's success in an independent life and certain quality of life is predicted by the level of language that a person has over and above intellectual disability and other co-occurring conditions. So let's talk more about language. This is a kind of a rough distribution. We can see there's about 30% who remain minimally verbal, about 25% who today have no language impairment. They, of course, continue to have problems with communication, but not in the linguistic code, and then almost half who have some form of language impairment. But they do learn to speak, but they never are quite at the sophisticated linguistic level of their peers. And let me start by talking about these two groups, because that's where we started our work, the children who do have some language. And in an initial study that I did with my postdoc, we were trying to understand the heterogeneity even among the children who do acquire spoken language. And this is a sample of, quite large sample of children between the ages of about 5 and 16. And we gave them different language tests, language of higher order grammar and meaning, a non-word repetition test, which is in green, vocabulary in red, and articulation, how well they could pronounce the speech sounds, in purple. And the children fell into these two groups, where 100 is the average score on these tests. And you can see the ALN group, which stands for Autism Language Normal. They are average across all these different aspects of the linguistic code, whereas the ALI group show this uneven profile. And while in these older children they had pretty good articulation, could pronounce the speech sounds well, they had difficulties with non-word repetition, vocabulary, and higher order grammar and syntax. And we call them the autism language impaired group. And we found the fact that this is broad. Of course, it's really a continuum, but you can roughly divide the children this way. And then we went on to ask about how does the language problem travel in families of children with autism. We know that autism itself has pretty high heritability. Well, what about the language problems? So we had families where we tested the child with autism and decided if they had normal or impaired language, their siblings, and we gave them language tests and reading tests, and the parents, we asked about their family history. And what we found was that in the siblings, if the child with autism had language impairment, their language scores were lower than the siblings of the children with autism who had normal language scores. And if we looked at the parents, we saw that they had, if the child with autism had language problems, the parents too had a higher history of language problems. And most interestingly, it was an increase in the mothers of the children who had language problems and autism. So some of this is traveling in the mothers. Of course, the fathers, it was also higher, but the biggest difference came with the mothers. So we see then that the language problems is traveling with families. Let me move into talking about the brain. We know that in the typical brain, for most of us, the linguistic code is primarily in the left hemisphere, the left half of the brain, and there are two critical regions, this Broca's area in the front part of the brain, outlined in green, and then in the back part of the brain, in Wernicke's area, and here I've outlined one piece of it, the planum temporale, which is the part that we've measured in many of our studies. And so we started to do MRI studies with children with autism, and this is just to show that we prepare the children well, because getting into a scanner is a pretty challenging activity for anyone, but most especially children with autism. So we prepare them quite a lot, and it's not quite as easy as my granddaughter in this picture seems to think it is. And we measured then the brain volumes of those two areas, that green area and the orange area, okay, in both the left and the right hemisphere. And what you find, so in blue are our typical control children, and you see everything here it's bigger in the left hemisphere. That's what this asymmetry index indicates. However, we found that in the frontal region, that green area was significantly less asymmetric in the children with autism. It was more evenly sized on both sides. And this has been replicated now many times. And then in the posterior region, we saw actually that it was in that orange area was significantly larger in autism. And while the frontal asymmetry did not travel in the siblings, here we see the siblings showing an intermediate pattern. So it was not as, it also showed some exaggerated asymmetry, but not quite to the extent that we saw in the children with autism itself. So we see these differences in asymmetry. We've then also done, along with many others, functional MRI studies, and this is where you're in the scanner and we look to see which parts of the brain are most active when you are doing some sort of a task, and in our studies, they're doing a linguistic task. And in initial studies that were done, both by Marcel Just and his colleagues, and then we replicated this with a slightly different task, in adults, we saw both reduced activation in that frontal language area, which is less asymmetric, and we also saw that there was reduced connectivity. So there are these two language regions in the front and the back part of the brain, but what's most critical is for those two parts of the brain to work together. And they are connected by both primary and secondary pathways that transmit information. And you see very close correlation between, in a typical person, the activity in the front and the back part of the brain. They're working together. And we saw less connectivity, functional connectivity, in this first set of studies was with adults with autism. And this is, let me point out, in adults who have intact language, okay? They don't have problems with the linguistic code, but nevertheless, the way that the brains are processing language is showing some differences. And then in adolescence, we used a somewhat different task. Again, here we found less left hemisphere asymmetry, so it seemed the adolescents in this production task were using both halves of the brain more equally than we would see in typical individuals. And again, we found this reduced correlation, this reduced connectivity between the frontal and the posterior parts of the brain. Okay, so let me summarize then this series of studies. There's enormous heterogeneity in the profiles and in the family history, and we see this atypical structural and functional asymmetry. That too travels somewhat in the families, because we call that sometimes an endophenotype, and we also saw this reduced connectivity. I don't know of any functional MRI studies with older siblings who don't have autism, so I can't report on whether that does or doesn't travel in families based on studies of older children. So now what I want to do is to turn to the other end of the age spectrum, to start with babies, and to ask the question, how early do these distinctive patterns of brain organization for language emerge, and how early can we predict language outcomes? How early do the language problems begin to appear in autism? More broadly, this is work on looking at risk factors in early development of autism. And to do this, we use a particular design which has become very popular. There are about 26 or 27 groups all over the world at this point who are using this design. Because we know that autism is highly heritable, we study families where there is already one child diagnosed with autism. And this family then has a baby, and we recruit them into our study as early as we can. In our case, we're recruiting at the age of 3 months, and we follow those babies for 36 months, at which point we can do a definitive diagnostic evaluation. Does this baby have autism or not? And what we know based on the accumulation of data from many studies is that about 1 in 5 of those babies, those younger siblings, is going to end up with an autism diagnosis. And so if we have a large enough sample, we're going to be able to identify these longitudinal patterns from birth. Okay? And the work that I've been doing on this now for 13, 14 years is in collaboration with Professor Charles Nelson from Boston Children's Hospital. And what we're doing in our work is we do a great deal. We're looking at the brain activity and early speech and language processing. We also have a whole other series of tasks that we do with the babies that I won't talk about, that focuses on face processing and social engagement. And we use different methods to tap brain functioning. It's much more challenging to do MRI studies, and you certainly can't do functional MRI studies with a baby unless they're asleep in the scanner. So we use electrophysiology, EEG, and ERP. We're also using another technology that I won't speak about today, functional near-infrared spectroscopy, which is somewhat more like, I call the poor man's MRI. And we're doing that to look at differences in brain function and early organization. So this is actually a summary of all the different things that we're doing. And our children come in at 3, 6, 9, 12, 18, 24, and 36 months of age. They come into the lab. Of course, we're missing quite a few visits from quite a few babies. Here you can imagine what a challenge this is for families to do. And we do baseline EEG And then when they're looking at faces or speech, which I'll talk about, we do some eye tracking studies. We do behavioral measures. We use the Mullen scales, which is a developmental scales that focuses on language and motor and visual organization. We do with the infants a baby version of the ADOS, and then we do the ADOS from age 18 months. The ADOS is the gold standard diagnostic evaluation for autism. And then we also do some other parent measures. And we also, between the ages of 6 and 12 months, have the parents fill out at home for us a weekly diary. And I'll start by talking about those data. Okay, so here we are, we're studying babies in a family that already has a child with autism. We do also actually, I should mention, have a control group. And these are babies for whom there's no family history. They do have an older sibling because we want to control for birth order, but they don't have any family history of autism or related neurodevelopmental disorders. And we were interested in seeing at what point do parents begin to express concerns about their child, and if so, what kinds of concerns are they expressing? And so we have them fill out these diaries, and there's various questions, some nice things, what cool things happened this week, did you do anything special, so that it has a kind of a positive tone. And then embedded in this is one question where we said, did you have any concerns about your baby this week? And if they answer yes, they tell us what they are. And then we went in and we classified what kinds of concerns did those parents express about their baby that week. Okay, now if anyone here has ever had a child, you know that we get lots of yeses and lots of different concerns. And then we classified them into medical concerns, sleep issues, because we were very interested to see whether these, in fact, are more frequent early on in the babies who end up with an autism diagnosis, or even just more frequent in the families where there is autism. And it turns out all babies have diarrhea, all babies have sleep problems, and so at this very young age, we did not find any group differences at all in any of those medical conditions. But we did classify their behavioral issues that they identified, and we classified them into 3 groups. On the left, you see the language problems. They were worried that their child wasn't doing something with language that they were hoping they would be doing. Social communication problems, perhaps things like doesn't make good eye contact this week, and then repetitive behaviors on the right, or sensory problems. In blue, you can see and this is now, I'm just showing you the data at 12 months. Blue, you can see the low-risk controls, okay? And those parents aren't terribly worried by 12 months. I should tell you they're more concerned earlier, which is interesting. In green, we see the high-risk babies, but who later were not diagnosed with autism. So we go back. So at 36 months, we've decided this is a child who did or didn't have autism, and then we classify them into these outcome groups. And in red, we see the children who ended up with a diagnosis of autism. And I think what's interesting is that it's language that the parents are expressing the most concern for at the ones that are realistic, okay, because this is a child who's going to end up with autism. And to be honest, this is not a new finding. We've known for 40, 50 years, the first thing that parents worry about when they speak to their pediatrician about a child with autism is that they are worried about their language. Okay, but in this study, we were doing it not retrospectively, but this is prospective. and the parents are sensitive and picking something up, okay? And what they're picking up is something that we measured then in the lab at 12 months, where we taped the child interacting with the parent, but also with the examiner. It didn't matter who they were interacting with. And what you see here is that the red group, the group ending up with an autism diagnosis, are in fact vocalizing less. They're not using many words at 12 months. Nobody has a lot of words at 12 months, but just babbling and using speech sounds. And they are just overall, their vocalization rate is lower. And it's a frequency measure, but the parents are somehow sensitive to this notion that that their child is just not babbling as much as I would have expected. And I think there's a lesson there that we should be listening to parents so much more than often we do. And then we looked at on our Mullen, we've got measures on the left of expressive language over time, beginning at 6 months to 36 months, and then receptive language on these scales, and on the right, the total verbal quotient. And you see that over time, the children who end up with an autism diagnosis are behind the ones who don't end up with a diagnosis. I should say that we're seeing this even though every child in our study, and it was a pretty large sample, and we had 28 children who ended up with an autism diagnosis, they all had actually fairly high language skills. They did all learn to speak, which is interesting and probably a biased sample, but part of the issue is these are very vigilant families, and as soon as there was a small problem, they had access to quite high-level early intervention that we encouraged the families to take advantage of. So we see that language is falling behind, nevertheless, to where it could have been. So we then moved into wanting to know what are the underlying brain mechanisms that might travel with this. What's going on in the brain and how the brain is processing language. So in infancy, we looked at this in the first year of life. What's going on during the first year of life is that babies are learning to perceive the speech sounds of their language. They are also learning words, and we now know they actually understand more words than we used to give them credit for, even as young as 6 to 9 months, long before they start to use words themselves. But their speech processing does show important developmental changes. And we used their brain response to simple speech sounds as a way of asking the question, when does that atypical brain asymmetry emerge in response to a speech sounds? How early do we see that in the high-risk infants? And then what about the functional connectivity between the frontal and the posterior regions? Do we see reduced connectivity in the high-risk infants as a group? And then more specifically, what do we see in the infants who end up with an autism diagnosis? So this is how we do our work. We use this high-density EEG cap. It started off with 64, and now we have 128 electrodes that are embedded in this cap, which we use because this goes on very easily and is well tolerated by infants. So we have relatively little data loss. And the baby is just sitting on their mom's lap, and they may be watching somebody blow bubbles, they may be watching a screensaver, but all the time they're just hearing a sequence of different speech sounds, das and tas, okay? And what we looked at was a part of the wave, so you get the brain wave and you can divide it into the event-related potential, the wave that occurs right after the speech sound, and you average it over the hundreds of speech sounds that they've heard. And the late slow wave, which is at about 300 to 700 milliseconds after the speech sound begins, is sensitive to lateralization, to which side of the brain. Is it slightly faster, which it is for us, slightly faster in the left and higher, more robust response in the left hemisphere compared to the right? And that's what we were asking about these babies. And what you see here on the left, at the top is 6-month-olds, 9-month-olds, and then 12-month-olds at the bottom. In blue are our low-risk controls, and on the right we have our high-risk babies, combined autism outcome and non-autism outcome. And what you see here in this box is that the low-risk controls, by 9 months, the two lines, the dotted line is the right hemisphere, and the blue line, the solid line is the left hemisphere, and we see that some asymmetry has emerged by 9 months and is maintained at 12 months. But in contrast, we don't see any difference between the left and the right hemisphere in our high-risk babies. And this shows that for this particular task, where lateralization emerges by 9 months, we are not seeing that left hemisphere advantage in processing language in infants at high risk for autism. And then later, we were able to reanalyze our data with a larger sample, and now we were able to separate out the infants who did develop autism from those who didn't, because those were mushed together in the previous graph. And this is what you see here, and this is a summary of the lateralization. In blue are our controls, and the solid line, you see the left hemisphere blue block there. In the low-risk controls, in green, there's actually no difference between the left and the right hemisphere. But what we do see here in the infants who ended up with autism is that, in fact, they are showing more response in the right hemisphere. So they're showing a kind of reversed lateralization. And this emerges, this is data from the 12-month-old babies. Then we looked at functional connectivity. And in a similar way as we do with MRI, where you look at the sort of statistical correlation between response in those frontal regions to the ones at the back of the brain, in both the left and the right hemisphere. Here we used the EEG response. We used a measure of linear coherence in the gamma frequency band and asked how synchronous are the signals in the front areas with the ones in the posterior brain regions in our two groups and then 3 groups of infants. And what we found is that at 6 months on the left here, there are no differences in functional connectivity between our high and low risk babies. But what we see is that at 12 months, whereas functional connectivity has increased, as we would expect, in the low risk controls, it has in fact decreased, although that was not statistically significant. And now we're seeing significant differences. Again, this is combining the different outcome groups. So then when we separate out who ended up with an autism diagnosis, in red here, we see they have the lowest functional connectivity. And that, as reminiscent of some of our work with the older siblings, in the first part of my talk, the siblings who don't end up with autism show an intermediate pattern here of less functional connectivity than the low-risk controls, but more than the infants who end up with autism. So we see these early patterns, and the brain organization for language emerges pretty early in development, and there is something about carrying the heritability for autism that leads to this atypical organization for language. And I want to say 2 things about that now, because otherwise I'll forget. One is, I don't think this is specific to language, okay? This pattern of atypical brain asymmetry and reduced functional connectivity, particularly long-range connectivity. We've also seen when we look at our data on face processing, okay, in autism. So that's one thing. This is not just about language. It's something about how the brain is organized for higher level social cognition and language. And the second point I want to make is I don't think this is specific to autism. Okay, I think this is specific, probably patterns that we see across neurodevelopmental disorders, although there have not been studies, except a little bit in dyslexia, of infants at risk for other neurodevelopmental disorders. This whole idea that you'd have reduced connectivity and atypical lateralization is a pattern of brain organization that does travel across different neurodevelopmental disorders. But here, we're seeing that those patterns emerge in autism, whether or not the infants have impaired language. I now want to turn to talk about the minimally verbal. These are the children who, despite, in our samples certainly, they had a fairly early diagnosis, they had access to pretty high-level interventions, they nevertheless failed to acquire spoken language. And we actually know relatively little about them because it's only recently that people have begun to study the minimally verbal. And I have to say, I think you can still count us on one hand. And, you know, we're one group that's been doing this. My colleagues at UCLA have been doing this work. I think there's growing interest. And then, of course, here in Spain, Wolfram has really taken the lead, I think, in Europe. I don't think anyone else here is doing this either. And I think this is... I think the reason we haven't for a long time is that this is a very challenging group of children, and I think it's also very challenging to have figured out how can we answer this key question: why don't they speak? Okay, and until we know why they don't speak, understanding what kinds of interventions we need to develop. And clearly we need to do something that's different from the standard autism. High quality, very effective behavioral interventions. This is the direction we need to go. So I think there's lots of potential explanations, and this list is not exhaustive. Lack of motivation, they don't understand intentional communication, they don't establish joint attention, they have symbolic deficits, imitation problems, intellectual disability, speech motor impairments, difficulties processing sounds, and other differences in the neurobiological mechanisms. And this is kind of the list that we have focused on. And the answer, I can tell you, it's not like you say, well, here are all these possible explanations. Let's find out which answer is correct. And the answer which is correct is all of the above. Okay? And the second answer is that what explains why one child didn't acquire spoken language is not the same set of factors that explains what another child. That there is as much heterogeneity in this population as we're going to see across the whole spectrum. So we did start out asking about behavioral correlates. And we have a sample of about, at this point we've seen about 90, and I think this particular study was based on 43 children and adolescents over the age of 5. And we had very good and objective measures of response to joint attention, initiating joint attention, behavioral regulation, and this could be non-linguistically using different means for establishing that. Their level of play, to look at symbolic deficits, imitation, and this is not oral motor imitation. This is manual with their hands and imitating actions on objects, okay? And their IQ level, looking at intellectual disability, and because we had a wide age range, we were interested in whether age was a predictor. And we had an objective measure of expressive language because there's variability. Some have no sounds, no words. Others have just sounds, no words. Others have some more words, but still below about 20 to 30. So there's some variability. And what explains that variability in a much more constrained space in this group of minimally verbal? It turns out joint attention and age were not correlated. They really played no role at all. Play and imitation were strong predictors, as was intellectual ability, cognitive level. But we found that even when you controlled for cognitive level, play and imitation were two predictors of how much language they did have. And of all of them, imitation was the single best predictor. And this is striking because, as I said, it's not oral motor or speech. This is manual imitation. So a kind of more general measure of imitation. I'm not saying it could be that oral motor imitation would be even more predictive, but we didn't assess that. I've been working for many years now with someone who was my doctoral student, then my postdoc, and is now moving into a collaborative role, Karen Chanowski, and she is a speech scientist who became interested in autism. She's also a speech therapist who's had quite a bit of experience. And she became very interested in the idea that these minimally verbal children have childhood apraxia of speech, which I'll talk about. It's a rare disorder, and it involves speech precision and consistency, okay? That every time we speak, if I repeat a word multiple times, it's going to come out more or less the same way, okay? And that's just because of the way our brain organizes so that it becomes easier to understand. And these children who have childhood apraxia of speech, which is an independent diagnosis of a speech motor disorder, they have difficulties in this area, okay? And it's not due to problems at the periphery. It's not their mouth and jaw. This is a brain disorder, okay? The brain, it's the brain centers that put together the speech output for us all. That's where things are going wrong, though we know relatively little about it. And so the question is, do some minimally verbal kids have co-occurring childhood apraxia of speech? And the answer, here are some of the signs that you look for, and you code whatever speech they do produce. So of course you can't even diagnose this in the nonverbal children, but they make all kinds of speech problems, problems with vowels, problems with consonants. Their rate may be different. They distort sounds, they miss out sounds, and they have trouble producing sounds. And what we administered as part of the battery tests that I haven't spoken about is called the Kaufman Speech Praxis Test, and you just are asking the child to make different speech sounds, okay? And we found quite high rates of CAS in our minimally verbal children. On the left here, we had about 12 who didn't show any signs of CAS, no speech motor problems. So that tells us not every child who doesn't speak has this problem. The largest number had some form of a speech disorder, but it didn't quite meet criteria for CAS, which is that they had to have at least 5 different signs. And then we had a significant number with CAS, and then the last group on the right, they're completely nonverbal, so we can't even say, but in my mind, that's perhaps an even more extreme example of not being able to formulate a speech sound at all. What's striking about this is that we also looked at this in the group of children we call low verbal. So they have more than 20 words, but they are not very fluent. Okay, they have a few fixed phrases, they have somewhat more words, they're still pretty low verbal. And when we started this project, we thought, well, they're sort of the same as the ones who have almost no words at all, because they do not have anything close to fluent speech or, significant sentences, let alone bad, omitting grammar and so forth. But it turns out that's not true. Those two groups really differentiate. We never saw signs of CAS in the low verbal group, okay? Once you get to if you've got some phrases, and this was, of course, independent of age, then you didn't have CAS. So this is very specific to the children who have the worst outcomes in language, and that just summarize this. Over 75% have some form of speech motor disorder in this group, and 33% of the variance, about a third of the variance to explain how much vocabulary a child is able to use, could be explained by their speech motor ability, even within this very restricted group. So it's clearly impacting. While it's an independent disorder, it's impacting their ability to acquire vocabulary in the spoken modality. We then looked at, I'm going to skip through this a little bit, sound processing. Do these minimally verbal children have problems processing sounds? And in particular, we were interested in, could they process, does their brain, and this was not a behavioral task. This is, we're just putting back that EEG cap, and they're listening to speech sounds. And the speech sounds consist of the oddball, there's the same sound, and then occasionally there's a sound that's louder than the one before or quieter than the one before. We counterbalance that. Does the brain show a different response to that? The most important is this middle condition, segregated, where you've got that sound stream, but overlaid is another sequence of sounds, so that you're trying to detect that deviant sound in noise. It's a bit what we call the cocktail problem, being able to understand. It's my time, okay. I'm going to skip through to say that response to that did correlate with vocabulary in the minimally verbal group. And I just want to end with the underlying brain mechanisms. We have tried MRIs on these kids, and in particular, drawing on the work of Frank Gunther. We're interested in that pathway that's important for speech initiation, to produce the program of speech output. Okay, given that these kids have problems in this area. And so they're lying in the scanner and they see a picture and they name it. Okay, we had almost no success with the minimally verbal to get them to do this and to lie still enough. What we see is that we see this nice, robust activation in the controls and in the autism, or that there was more variability. These are verbal autistic. And then this is the scan from one minimally verbal. So it's a tease because it's almost like an anecdote. But what you see here is that this young lady, she was an adolescent girl, showed no activation in that prefrontal region. She showed more significant activation, neither in the left nor the right hemisphere, much more posterior activation. So she effortfully is able to label pictures, but she is not relying on the same brain mechanisms. So to conclude, language, I think, is still a canary in the coal mine. It's not a core symptom, but it tells us a great deal about autism. In infants, we see differences in their how their brain is organized, and these are the early emerging problems. And for the children who don't acquire spoken language, there's a number of unique behavioral and brain factors. We need to develop effective interventions that can be implemented early enough to promote development in all children, and this is a direction that we have been working on a little bit with colleagues at Beth Israel, and are now working on some more using some different approaches. And thank you, and I'm sorry I went over time.